presenter for this afternoon is Annabel Milonas. Annabel's had a career that's extensively worked in the deteriorating patient spaces and also in resuscitation. She's currently working as an education coordinator for the surgical and cardiac clinical services at Austin Health. The most interesting part of her bio, and I need to ask her a question about that, is she's currently doing her second master's, and it's in terrorism and security studies. So I'm wondering what's going on at Austin Health. So fill us in. Today she's going to talk about post-resuscitation management of cardiac arrest patients in the critical care environment, a retrospective audit of compliance with evidence-based guidelines. Welcome.
Yes, lovely, thank you. Thank you, Kylie. Right. Oh, no, I can't see that down there. Okay, thank you, Kylie, very much for the introduction, and thank you, everyone, for coming to listen to my talk. I do have a couple of acknowledgements, so I'd like to acknowledge my co-authors in this study that we did, and that's Associate Professor Anna Hutchinson, Dr. David Charlesworth, Andrea Dorick, Dr. John Green, and Professor Julie Considine, who's in the audience today. The other thing I would like to acknowledge the Northern Health Research Department, who I got a grant to undertake this research. So I guess today, wait a minute, I'll get this. Today I'm going to be talking about my research into ED and ICU nurses and their compliance to the post-resuscitation phase of a cardiac arrest. And, you know, I think it follows on from Marette's themes when she started talking on day one about the importance of the pre and post phases. We've concentrated a lot on ALS and the intracardiac arrest phase, but it's what we do afterwards and what we do before that actually affects patient outcomes. So I guess my interest in this area comes from what Kylie said is my time in emergency rooms with postgrad students and also as a resus coordinator. And one of my things was that we were really good in the intra phase of a cardiac arrest, but it was afterwards, and it was kind of like someone said, the sedation, it was Wayne who said everyone just takes off and you're kind of left with this patient waiting for ICU. So my research, I'll move this. So the background, what do we know? So we know essentially that there's a clear relationship, and that's been evidenced and more so nowadays is being evidenced that post-resuscitation care and survival and functional status it is really important. And, you know, Jerry Nolan was one of the biggest people that acknowledged this process after a cardiac arrest, this post-arrest syndrome, and that consists of things like prevention of secondary brain injury, because we have this brain anoxic injury, also prevention of myocardial dysfunction and management of this whole systemic response that happens to our heart after a cardiac arrest, as well as managing the issues related to cardiac arrest. And that the Australian Resus Council recommends protocol-driven care to enhance the chance of survival. And, you know, these, obviously in 2016, these changed to increase the to give us more evidence in that space. My study was before the 2016 guidelines came out, so I'll alert to that as we go along. And that healthcare providers have really got an obligation to ensure protocol-driven post-arrest care. And I think I really like Marette's talk when she said about ED nurses being intensely monitoring patients in that cardiac arrest phase, and I think that we've got a really big responsibility there. So the aim of my study was to examine adherence to best practice guidelines in the first 24 hours post-resuscitation of a patient. So that was the aim, and the method. So the method was essentially that I did a retrospective audit of medical records, and it's 2010 to 13, so it is well before the 16 guidelines, but not a lot changed in the post-resuscitation guidelines with regards to what the study outcomes produced. And I took a sample of 200 patients that had suffered an out-of-hospital cardiac arrest and survived for the first 24 hours and admitted to ICU via the ED. Now, although I'm not going to talk about it today, I did actually collect the pre-hospital data as well of all these 200 patients. But the research is focusing on the compliance of ED and ICU nurses, so it doesn't form this part. The setting was in 2 health care services in Melbourne. The Northern, which all of them have, I think you've heard a lot of Northern talks, so you understand what Northern is because they've put their hospital up there. And also Meredith's just talked about Eastern Health, so that was the other sample site that I took. So the data collection, so I essentially collected data on primary cardiac arrest characteristics, oxygenation and ventilation management, cardiovascular care, neurological care and patient outcomes. And I did this with tap forms on an iPad and looked through the data, and there was a huge amount of data that came out. Things like oxygenation, all their gases, their initial gases, their ongoing gases, their gases in ICU, looking at the time to ECG, time to cath lab. So there was a lot of data in that, and I'll present some of that now. I also looked at in-hospital mortality rates, neurological care like blood pressure control, TTM and blood glucose control. So I'm going to present just the main themes really, and although I'm not going to be as funny as David was before, and there isn't many drugs in mine, but I hope that you can take away something to your environment so that you can add to your protocol-driven care. So, the results. So, essentially, the major results of the study is it had 4 major themes, and they were that, and I'm going to go into these a little bit, but that there was an increased use of FiO2 of 1 and hyperoxia was common in the first 24 hours of post-resuscitation management. There was variability in cardiac care. There was timely 12-lead ECG for the site's protocols, but actually not for the national standards. There was delays in transfer to cardiac cath lab. And there was suboptimal neurological care, and this is really important, that only 50% of patients actually got targeted temperature management, and there was a failure in 50% of them. And there was a high incidence of hypoglycemia, and we know from studies that hypoglycemia really increases your mortality rate. And there was an association between in-hospital mortality and specific elements of post-resuscitation care during the first 24 hours. Okay, so if we look at these results, hyperoxia was common in the ED, and hypercapnia was common during ED care. I know these look a little bit complicated, but I'll just give you the main themes from them. So hypercapnia was common during ED care. ED highest median PaCO2 was 67, and there was a wide variability in range from 56 to 88 millimetres of mercury. And in the ED, acidosis was more common and more profound than in ICU. So ED, the median lowest pH clearly suggests acidosis. So the median was about 7.04. And although the PaO2 levels were greater than 300, it was actually uncommon in our study, there was a considerable proportion of patients that actually had a PaO2 between 150 and 200, suggesting a really underuse of oxygen titration protocols. That may have changed in the time since this study because of the awareness of nurses and the titration of oxygen in both the deterioration as well as the post-arrest phase, and also associated with things like change to protocols of chest pain and hyperoxia and the damage that can do. So there was variability in cardiac care. There was timely ECG, 12-lead ECG. The majority of patients had a systolic below 100, and there was delays in transfer. So the ED median time to first 12-lead ECG in the ED was 10 minutes, with 28 patients having an ECG immediately on arrival. There was a systolic blood pressure of less than 100 was present in 15% of the patients, but 26 of these patients actually received inotropes. So when we're talking about the ECG, the median time to 12-lead ECG was 10 minutes, which is actually outside the national standard of 5 minutes. And interestingly, talking about Moretz, going back to the whole aim of trying to get an ECG within 20 minutes of ROSC, interestingly enough, both these health services have really wide catchment areas. And so unless and I know that there's been change in the pre-hospital environment, but unless you can actually get that ECG in the pre-hospital environment, then that, according to my study and the time, you're not ever going to get a 20-minute post-ROSC. Because of the distance, certainly in these two health services, so it's about getting the pre-hospital and the pre-ECG notification, which is happening now. So the national standard for PCI is a daughter balloon inflation time of 90 minutes. In our study, the median was 67 minutes, which leaves at least 30 minutes for commencement of the procedure to the point of balloon inflation. At the time that I did the study, both hospitals had immature code STEMI systems. So when I say immature, I mean that they had code STEMI systems, but they weren't full 24/7 cardiac arrest centres. Like, for example, Northern has way more advanced, that changed in about 2013, 2014, where they have an on-call, they have 24/7 cardiac cath lab capability. So there was suboptimal neurological care. There was a high incidence of hyperglycemia and a failure to provide targeted temperature management in almost 50% of the patients. So with the hyperglycemia, it was common in the patients in ED. Essentially, in 65.5% of patients, they had a blood glucose level of above 10. And that's really quite serious. And it's interesting, I was practicing this with some colleagues, and they said, you know what? The thing is that we don't think of hyperglycemia because we take a glucose and go, no, it's not low, that's fine, and carry on. And it's just something that, you always think hypoglycemia, but I think it's about thinking about glucose over 10. And ICU obviously had a greater control of BGL levels in the majority of their patients. So most patients had an initial BGL on arrival to ED, which we would expect because we do that as our primary survey. But there was no ongoing monitoring, and there was a real lack of ED glycemic control protocols in both centres. Now the reason that you have things, it seemed to me that some of this we start stuff but we don't go on, and there is competing priorities within ED departments, and there's a lot of rush and a roar to get things done, so that could be explained. With regards to TTM, in ED, it was commenced in 65% of the patients, and so 51% of them, though, did not actually receive any TTM within the first 24 hours, but there was no difference between sites. And I will quantify that at the time that I did this research, there was a RINSE trial going on in Victoria at that time, and that actually asked for the pre-hospital administration of 30 ml per kilo of cold normal saline. So that did affect some of the results. But the median, interestingly, though, the median time to reaching the target temperature of 33 degrees was actually 11.3 hours. So essentially we're asking to be cooled, in this stage we were asking to be cooled, and it was taking us on average about 11 hours to get there. So since the time of the study, obviously you all know, and Marit highlighted this, there was the change to practice across Victoria from the Nielsen study, and now so that is one change that happened during this, and certainly at Austin Health we have a 36 plus or minus a few percent. So we know that we can't keep them right on 36 degrees. So a lot of hospitals have changed that protocol, but the theme is that they're keeping them cool and avoiding hyperexia. The patient outcomes. So the in-hospital mortality in these patients were 63%. So 126 of these patients died. But for the patients that actually survived, 54% of them went home, and 21% 0.6% went to rehab. Now, I know that normally after a cardiac arrest we use a CPC score, but I actually looked at a normal GCS on hospital discharge because I found it very difficult in this data to actually find a CPC score, so that was actually a limitation. But in actual fact, in 59 of the 74 that survived, they had a normal GCS. For all the managers in the room, the median ED length of stay was 2.75 hours, so under the neat targets, so that was good. And ICU length of stay was 3.4 days, which is interesting because there was change in the 2016 guidelines of prognostication and how we're doing it way too early. And so if you're only staying there for 3 days, they say don't start for 3 days. So that may be an issue in the future. The patients who died during hospital admission were significantly more likely to have a lower pH and a higher BGL, both in the ED and ICU, and there was a clear association between in-hospital mortality and specific elements of post-resuscitation care. So essentially, hypercapnia in the ED and hyperoxia in ICU increased the likelihood of death, and the association between hyperoxia as a key predictor of mortality is supported by other studies. So further research is obviously required to determine the optimal PaCO2 targets, and there is studies in this space on acidosis and pH, and also in studies, I know, for example, in Victoria, the Alfred are doing the EXACT trial. There's a multi-centre study that will look at oxygen titration in the post-resuscitation phase. But it raises the questions about whether guidelines for optimising acid-base balance and expected pH trajectory would be useful in post-resus care. So I concur with you, Murat, but basically nurses have a major responsibility to actually monitor intensively patients that have suffered cardiac arrest, and it does influence patient outcomes, and it should be a quality indicator that we adhere to and comply to the national guidelines. We do have national guidelines, and you know, talking to a few of you around the trap, some of you may have protocols, but I know, so both these, we know about VF cooling of post-VF arrest patients, but it's have you got that whole protocol? Yes, you've got the guidelines, but it's actually the effective implementation of the guidelines that's required. And it needs to span the whole patient journey and be context specific. Thank you very much. Good. Oh, no. Surely you don't, Murat.
Sorry about that.
Oh, that's all right.
Thank you for a good presentation.
Yep.
And I think that the most important words you said in the end, when you said that these patients are almost 3 hours in the ED, which really means that if the EMS has them for like 30 minutes to an hour and a half after the heart starts beating, and you guys have them 3 hours, we have almost 5 hours of time that nobody's actually been interested in before.
Yeah.
There's almost no studies on this, and we really don't know how everything we do during those hours actually affects the patient. So we should really, really do some kind of multi-center studies looking at the things that happens, and then targeted temperature management at 11 hours is like, why even start anymore?
Yeah.
I mean, we know from animal studies that you should start in a couple of hours, and after that it just goes down.
Yeah.
So we need to be more effective.
Yep. Thank you. Thank you very much.